Good morning, everyone, or good afternoon in some places. Charles Steller, President and CEO at WEDI, and it's really a pleasure to have each of you participating in today's member position advisory meeting. This is our opportunity to talk about specific issues being presented to WEDI in a way that we can provide our comments on these important topics. So we call this an MPA. This is our second one this year, second one in the last 2 months, actually. But I wanted to just share a few thoughts about WEDI. Everyone on here is, I believe, already a member, but it's always good to be reminded of how we all got started, and if so, and exactly why this event is so important. For WEDI, we were formed in 1991 by then Secretary of HHS, Louis Sullivan, and you will appreciate over the years the evolution of WEDI and the number of accomplishments we have made. As you might recall also, but it's always good to be reminded that WEDI was named in the 1996 HIPAA legislation as an advisor to the Secretary of HHS. We continue to represent payers, providers, vendors, but we're also honored to have on our board several important groups, including CMS, ONC, and we are have a productive working relationships with CMS and OCR and ONC as well. We are a multi-stakeholder organization of plans, providers, vendors, and the other part of this is the standards development organizations, as well as state and federal government. WEDI is composed of 18 work groups, task groups, including the provider information work group that's bringing us together today. Our roles are to convene, collaborate, educate, and influence. And with that, I'm going to turn it over to Ed Hafner, the chair-elect for WEDI, who's going to run through what the MPA is and what our next steps are.
Yeah, thank you, Charles, and also give you a little pep talk as well. Earlier this year, WEDI's policy committee, chaired by Bob Bowman and Jay Eisenstock, with a lot of assistance from our WEDI chair, Nancy Spector, evaluated the policy advisory group process, we call it PAG, to modernize it and make it a more agile process to address topical issues, public-private sector proposals, and a wider variety of government regulation activities. But it's also aimed at getting you more engaged with us. If some of you remember the old PAG process, you needed to be in person. You're handed a colored paddle representing your stakeholder type in your organization, and you raised your paddle high to vote. Discussions were heavily guided, and being so formal, it limited some conversations. The meetings were also harder to organize, and it was a lot of planning to make it happen. So the process did not allow us to be agile to quickly spin up PAGs. We've evolved through these COVID times and become more efficient operating in a virtual environment. The MPA process utilizes virtual meetings and possibly a hybrid in-person approach in the future, taking advantage of a more engaging process that encourages conversation, welcomes dissenting views, but in a cordial way, and conducts surveys in real time that encourages attendance from our government friends as well, that helps us create the official WEDI responses. You can make a difference, not only by shaping our WEDI responses through this MPA that we're conducting today, but also we can learn from each other across our different stakeholder groups' perspectives, and also from your own peer groups, learn from perspectives there as well. Next slide, please. Today's MPA event is triggered by an RFI from CMS entitled Request for Information, National Directory of Healthcare Providers and Services. The RFI raises issues and questions about potential new policy related to a national directory. Now, oftentimes RFIs are a precursor to NPRM, so it's important to provide feedback to assist Health and Human Services through their thought process. Comments are due December 6th, and just a heads up, there is no timeline yet from the government to take action. But I encourage you today to fully engage. Feel free to participate. Even if you haven't been with us before, please do not hesitate to raise your hand, and Rob will go ahead and explain to you how to do that in a moment. We are a friendly and supportive group, and if we're not, Rob will fix that person who's not friendly. And also encourage you to learn about all our different perspectives. So Rob, take us away.
Well, thank you, Ed, and thank you, Charles. And let me add my welcome. We've got a wonderful group already on, so I think we're going to have a very robust discussion. So, Michael, if you can go to the next slide. Just briefly, I wanted to walk through our agenda for today. We'll spend the vast majority of the time walking through the RFI, the many questions that CMS has posed, and to help us do that, we have really an all-star group of facilitators. I'm so pleased that we have Michelle Berry, who is the current co-chair of the WEDI Provider Information Workgroup from Availity, Kim Sinclair from the Boston Medical Center Health Plan, Nancy Spector, current board chair from the AMA, April Todd from CAQH, Tammy Weaver from AMA, and I'll help out as well. So again, to emphasize what Ed said, this is your opportunity to help shape the perspective that WEDI is going to present to CMS on this very important issue. And we'll wrap up. I don't think we'll have any challenges spending 3 hours discussion about this. I think we could probably spend 3 days, but we're limited in time. I know you folks are busy, so I certainly appreciate you taking time out of your day to come and participate today. Next slide. So as always, and many of you have participated in WEDI events before, 2 ways to share your thoughts, to ask questions. One is through the chat feature, and I think we're all very aware of that. I'll try to keep up with that, and I'll try to share those perspectives. If you would prefer to be anonymous, and we've had that in the past, where you want to make a comment, but you don't necessarily want to have it attributed to you or your organization, you can send me a direct message through chat, and I will read your comment without attribution. So if that's something that would make it more comfortable for you, please do so. But again, we encourage you to be vocal, raise your hand. That's the wonderful aspect of Zoom. We can get to you and unmute you and have you ask your question or raise your issue. As always, we will make all of this information, the transcripts, the chat, all of it, including the recording, will be made available after the event. We'll email it to you. It may be helpful as you're developing your own comment letters for your organization. Next slide. So with that, we're going to jump right in. We're not going to spend too much time talking about the RFI, but I thought it was probably wise for us to walk through some of the high-level perspectives that CMS has put forward. So next slide. So these are all drawn directly from the RFI. So it's saying we, meaning the agency, believes that CMS may have an opportunity to alleviate some of the burdens, and they spend quite a bit of time in the background section of the RFI discussing some of the burdens, and in particular citing the great work done by CAQH in identifying some of the administrative challenges associated with reporting provider directory information. So they have an opportunity to alleviate some of these burdens and improve the state of provider directories through a CMS developed and maintained application programming interface. If you go to the next slide. So they also state a centralized, validated national data hub could help to alleviate current directory challenges by acting as a centralized data hub. For example, when a provider changes their office location, that provider must update at least 2 separate CMS systems, the National Plan and Provider Enumeration System, and PACOS, as well as an average of 20 separate payer directory per physician practice. We all know the challenges associated with directories. We know that there's no standardized approach, that each health plan has different requirements. Even within the government, they have different requirements. So I think we all understand the vision that CMS has. If you go to the next slide, Michael. So they state, we believe a modern healthcare provider directory should serve, and very important, multiple purposes for end users. So their vision goes beyond just looking at provider data for directory purposes, and we'll be discussing that today as well. In addition to helping patients locate providers that meet their individual needs and preferences, a modern healthcare directory should enable healthcare providers, payers, and others involved in patient care to identify one another's digital contact information, also referred to as digital endpoints, for interoperable electronic data interchange. So again, their vision is broad, and it'll be our job to really give CMS good advice on how best to move forward with this their vision for provider data. So if we go to the next slide. So we wanted just to start off with a poll, and again, these poll results are important. We will be leveraging the poll results in our comment letter, so I would encourage you all to vote. It only takes a second. But again, we really want to know, what your general level of knowledge is regarding some of the concepts put forward by CMS in this RFI. And it looks like we've got a very knowledgeable crowd. And again, even if you haven't read the RFI, I think you probably will have some perspectives on many of the questions that we will be discussing today. So I think we can close that out. I think it's a, not surprising with WEDI, a very knowledgeable crowd. So if we go to the next poll, we're very interested in folks to find out if you've been involved in other provider directory initiatives, such as Synaptic, Symphony in California, or other similar state initiatives. And if you are, what is your perspective on those initiatives? So let's see how the results are. Okay, I think we're going to relaunch that poll. Just hang on 1 second. Okay, here we go. We'll give it just a second. It looks like the vast majority of folks have not been involved in these initiatives. So a couple have, and looks like a mixed results for those that have been involved. So if that's good. Thank you, Michael. So we'll go to the next slide. And what we're going to do is sort of go back and forth with our various facilitators. And we'll start off, maybe I'll start off, I see her up top here. Michelle, maybe we'll have you kick off the first question. So you can go to the next slide, Michael. There we go. Thank you.
Absolutely. So a couple of things. Hopefully everybody can hear me pretty well. I apologize for the scratchiness. Just hang in there with me. The first question is really around what benefits or challenges may arise during this whole integration around the provider data, and including CMS systems like MPES, PCOS, and other Medicare, Medicaid systems into the National Directory Hub. And then another question that stems around this particular RFI question is what data elements for each of those systems would be important to include in the NDH? So if you think about that, we want to, reduce the amount of questions, and we want to reduce the amount of same questions. So our potential response from a WEDI perspective is really looking at combining MPES, PCOS, Medicare, Medicaid, care compare systems, reporting requirements, and really driving the collection process around streamlining that data. Also, should we urge the agency to map the data requirements for each of the federal programs to ensure no duplication of data? So again, these are the questions to the question. So I'm going to take a minute, see if we have any hands, any input.
And Michelle, when you think about it from the provider perspective, any type of streamlining or combining of reporting requirements, one would think would be a very positive step forward. I don't think there's any downside to try to do that. I see Tammy.
Tammy?
Yeah, see if I can get myself off mute here and lower my hand at the same time. So yeah, no, I would agree with that, Rob. And that's where I was thinking too. I think that I have a couple of thoughts on this space is that I think for the government to streamline, they have folks going to MPES and PCOS today. So I think that makes perfect sense. I think the thing to be cognizant of is, some of those systems have some known issues with some of the data and the data quality. So making sure that, you're cognizant of that and pulling over, good quality data. I think the other thing, when I think about the whole directory initiative in general, is this, I keep coming back to fitness for use. Every use case has a different fitness for use. And for some applications, it's really important just to know that the physicians at this address or the clinicians at this address. For others, you have to know that they're affiliated with this payer. For others, you have to, and I think that's what makes this all very nuanced and complicated. So I think in this area in particular, that for the government to streamline their own input, it would be fantastic. I think they've already sort of set a bar at some of the core data elements, name, practice address and location, specialty, some of just the basics on finding someone to find care. And I think the more streamlined that can be out of the gates, the better. So that's just some initial thoughts.
Right. And to add to Tammy, there also the no surprises HR 133 specifically calls out some data requirements around name. telephone number, phone number, also service location addresses. So there is defined data fields, but also, is there any other data accuracy information that would need to be collected? Some providers don't go in and update MPES often. And so some of that data, to Tammy's point, is latent. Jay? I see you have your hand raised. Jay?
Yeah, I was struggling to get off of mute. Thank you. It's a two-handed process apparently here. I wanted to get a thought across. I wasn't sure where the right place was, so I thought maybe here would be a good place to talk about it. So, one of the concepts here that's being discussed is this idea of the NDH being a centralized data hub, which conceptually has some real positives. But what I want to propose and want people to think about is, we have technology today that offers us the ability to do something that's much more of a decentralized approach using a federated data model, because there are sources of data such as the health plans, state and local government licensing boards, et cetera, that could be part of this centralized hub that is more logical than physical, if that makes sense. And this moves the paradigm of this concept of an NDH from here's one database that could unfortunately over time suffer the consequences of the current systems, which become out of date, not coordinated, and so on, to a model that allows this concept to extend across the industry. And further, it could be updated through using a publish and subscribe model that's also available there, that would allow for more of a real-time like interface. So I wanted to just propose that and set that out there for folks to consider.
Yeah, and Jay's Rob here. What's interesting is, and Robert in the chat has brought it up. The question is, if they build this and it's voluntary, will they get the participation and the accuracy that they're expecting? And so I'm interested in hearing from folks. Maybe I'll ask you, Tammy, first. Does this need to be mandated on providers? Is that the way to go, or is that too heavy a hand from the government?
That's a nice softball for me there, Rob. Yeah, so I think the problem with the mandates is that, if that was the only place you had to do it, that's one thing. But if that you have to do it there, and then you still have to continue to do it in 20 other places, which is what we've seen, which is where that gets difficult. And I'm seeing a comment in the chat here that I think hits the nail on the head, right? So the comment is about providers can have multiple specialties depending on where they're practicing. They can accept certain plans at certain locations. So, and even Jay, I love your comment about the federated, and I do think industry collaboration is totally necessary to really solve this. But that's where you get into what is the authoritative source of what that individual specialty is at that location for that plan. Is it dictated by the contract? So where's the authoritative source? And I think that's where this gets a little tricky.
No, excellent points. And I'm going to read a couple of comments, and then we'll go to Stanley, who's raised his hand. Summarily, says, I would have a concern that even a short lag between updating the centralized data and the information stored elsewhere could cause claim outcomes to differ from what is expected. Gail writes, even if mandated, it does not guarantee it will affect change. It is required via regulation today for providers to keep their NPES record updated. And the reality is that is not the case across all providers. that it is done today, and provider data can change not just by provider location, but by the payer they are contracted with. Excellent points. So let's turn to Stanley.
Yeah, and I, thanks, Rob. I certainly have a concern about defining what a provider is. We go through the process of billing providers and performing providers and referring providers. How are they to be enumerated or listed if they're different from system to system, and if they're different from health plan to health plan? I think that's a particular issue. And then there's different types of providers that might be recognized by one health plan, but not another. How are they to be identified and enumerated, if at all? So I think we've got a basic question of how do you define a provider before you put together a provider directory. Thanks.
Yeah, no, excellent point, Stanley. And what strikes me is we've got a situation where there's two separate sets of data in a sense. One is a core set that every health plan and every program would need. And then there's the other set which is very much plan specific. And would the NDH be able to capture the nuance, or would CMS expect that the health plan would simply pull the core data from the NDH and then be required to reach out to the provider for that second set of data elements? I don't know what folks feel about that. And I want to give some other folks. Kim, thank you for joining us today. What are your thoughts on, if they build it, if the provider data was relatively accurate, would it contain enough for a health plan to use effectively?
Yeah, thank you. I think it depends. It's really going to depend what's in there. So at least from, as I think about it, if I can get the bulk or almost everything we need from this, national single source, that's great. But if we still have to send out or follow up with just as many providers to ask them for another, half a dozen data elements or validate them that way, I worry about what the providers' reactions are going to be. So maybe it's reduced some of their burden, but not all. I also share concerns that we've heard already about the accuracy, and then how are you going to get the adoption? So again, the mandate has its own challenges, but if everyone's not using it, then it's not as effective for the health plans to invest in either.
Excellent point. And April, I see you've got your hand raised.
Yeah, I was just going to add in and say, just from our experience at CQH, where we're dealing with most of the providers in the country, I think every day, it's always better to be able to reduce the number of times you need to go to providers. So if there's a way that the federal government can do that, at least with their systems, would be helpful. But I think what's an important point to make, that I think a couple of others have made as well, is that expecting providers just to go there when it's not part of their workflow, or there isn't something related to them providing service is challenging because their days are so busy. And so I think, if there are ways that even, CMS could pull data from other sources that are coming from providers that do engage with other limited number of organizations that are trying to engage with them on a routine basis, gather that data that might be more current, that could help keep CMS's databases more current and more accurate. And then the last point I would make is that, there's always a lot of conversation around technology, and that, we just have to find a way for providers to submit things. I would say from our experience, it's very important to focus on provider engagement and to be reaching out to providers and ask, coming with data that might be accurate and asking them to clarify or to verify that information. So a few points there.
Excellent. Appreciate that. And Avinash has asked a very interesting question. has there been attempts to incentivize providers for submitting accurate data, such as purchasing data from them directly or offering a rebate potentially from the payer for timely and accurate submission? So in particular, to our friends from the plan world, if you do have a program like that, let us know in the chat. But I think we're going to move to the next question, but I will summarize here, and folks, correct me if I've not captured this accurately, but it appears we've got consensus around the idea that it would benefit providers to have a standardized and centralized approach to submitting their data to government programs. There's less optimism that the NDH would be able to capture at the level required by the plan all of the data to eliminate the plan's need to produce their own directory information. So let us know in the chat if that's inaccurate. And Ed, okay, sorry, yeah, let me see. Robert has, will the mandate require that the source be validated, i.e. licensings, even state licenses, also sanctioned list like OIG and SAM? This would be a big value add to get buy-in from payers. So that's something to consider. And as well, oh yeah, so Stanley says linking to sanctions might be a turnoff for providers. We do have a question or a comment, or the question is, why can't we use social security number as a common unique ID to join multiple data sets, for example, a tax and state license, to pull up-to-date data that is refreshed without incremental input from providers? And I think that gets to the point that April made, which is the more that we can draw from existing data sources lessens the burden on providers. So I think some great questions, great comments there. I think we're, as you can see, we can easily spend 3 hours probably on one question, but we'll move to the next. Michael, if you don't mind. And this is a little bit similar, and we'll be quick about this. I'll just go through it. So they're saying, listen, there are a lot of federal programs out there, and they list a whole bunch. Should the NDH interact with these, and if so, for what purpose? Personally, I don't see any downside with harmonizing all of the federal programs under one interface to reduce provider burden, but I'd be interested in the chat if anybody disagrees with that. And we do have Todd saying one thing to consider is the source of the data or edits. For example, can the change start with CAQH, NDH, or the health plan, and then how is that data then synthesized among all dependent systems? So a good point, Todd, that you're pulling data from different sources. It's got to be synthesized in an effective way. Good point. But not seeing any dissension on that. I think we can move to the next slide. And maybe I'll ask April to take the lead on this one, on the state and local issue.
Thanks, Rob. So on this particular question, they're asking for any relationship between state or local systems that could integrate with an NDH. So think of things such as licensing, credentialing, some of the Medicaid databases or public health, in particular, what of those data elements might be needed to interact with state and local systems, exchanges, other state level provider directories. So I think the key questions here to think about is, is it possible to have some harmonization between state and federal requirements? What would be things that could potentially be achieved? What things would be challenging within this space? We know there are a lot of provider provider requirements, directory and otherwise, that are different at the state level versus the federal level.
So I guess a general question is, do states willingly follow along behind the federal government without a mandate? And I think that's a little bit rhetorical. We know the answer to that. Some states might and others would not. So would this type of approach require additional legislation to compel states, for example? What do folks think? Kim, yep, including state-specific requirements for data elements beyond the federal requirements would be beneficial. I don't think anybody would disagree with that. The more data elements. Now, one of the questions would be, would it be? And again, Ed, we've got a comment. Would it be easier for the feds to canonize state level data? That might be an option, as well as for the NDH to go out and request from the states a data feed. And then again, you've got two sets of data that have to be synthesized, and a lot of duplications and error. And I think that would apply not just to state level data, but any third party data source coming into the NDH other than having the provider themselves. Kate says, would it be too big of a lift to include state-specific requirements when there are states who have dramatically more requirements than others? I guess one of the questions might be, or solutions might be, to have the provider, when they say, okay, I'm located in Maryland, then they would be given the Maryland specific requirements that might cut down. I don't think it makes any sense to have all of the state requirements be required to be filled up by every provider. I think that would have to be made clear to CMS. And Jay, I see you've got your hand raised.
Yeah, so if you think about it, the directories that exist today are very use specific. Think about PICOs, think about MPES, think about some of these state and local systems we're talking about today. So the challenge, and maybe the question here is, could CMS or whomever essentially manage all of this so that there is one way to synthesize this data? And I mean, others have mentioned this, but that's the real challenge. I mean, do you start by determining all the use cases across the industry and based on that, determine what data is necessary and where that data comes from? And that's a huge challenge and a huge undertaking. And I'm not sure that, is it possible? Maybe just throw that out.
Excellent point. And Robert also mentions the state's data, government's data, payers' data, etc., are all for their own sort of unique purposes. So the work here is taking all of these data libraries and aligning them so that all the use case criteria is captured, not at all an easy task. So we've got a couple of hands. We're going to go April and then Ed.
So a couple of things here on the state level. I think, if we think beyond directories and think about what the state is responsible, particularly the state departments of insurance that have regulatory authority over a number of aspects of state data, there are a lot of commonalities between data that is collected for provider directories as well as that is data collected for network adequacy. And so I think one of the key questions to think about here is the relationship between the federal government's authority and state Department of Insurance regulatory authority around data that is somewhat similar but used for different use cases, as a number of people mentioned different use cases. And just the the volume and the flexibility needed to be able to adapt to those changes and differences across the states that are very valid based on the different characteristics of the states and their geographies. And so that's in particular, I think would be a very difficult challenge to align with the different state regulatory requirements and their authorities.
And Ed, before we go to you, I guess one of the issues would be kind of phasing that portion in. So I think a lot of us I'm seeing agree with the concept that it would be wonderful to have that data feed coming from the states, in particular to decrease the reporting requirements for the provider. But there are a lot of challenges. So maybe that could be part of, you know, a second or third phase of the NDH. I know we get into phases a little bit later, but Ed, please go ahead.
Yeah, thank you. First of all, to everyone participating, awesome engagement. Just keep it up. You actually inspired me to make this comment. You know, looking at NPES as it is, it serves a specific purpose of associating NPIDs to you know, to providers, right? And you know, looking at what this directory could be, I think it's really important to have it be focused on a small set of use cases. And I believe it was mostly inspired by the No Surprises Act and the provider directory provision that's in there, you know, to be able to keep your directories updated, to be able to serve members or patients with accurate information. So if they could go ahead and be the source for a smaller set of data, allowing it to be able to be served easily through APIs that would, you know, be supportive in a very performant way, we wouldn't have to necessarily replace what's at the state, but could be a source of information, much like NPES is, to be able to provide information just on the demographics. And that just my thought of be careful not to expand too far.
Ed, would you be comfortable again with the idea of maybe phasing things in? So, you know, don't bite off too much at the beginning, but if things are going well and you've got buy-in from the states, it can always be expanded.
Yeah, definitely. I think it's important to be able to not only populate it, but to be able to serve it in a very easy, performant type of a way. And then if it was successful, I like where you're going, perhaps we can expand to be covering more use cases. But right now, if there's, gosh, if there's state problems and, you know, they can't trust that information, or if there's commercial health plan data that is, you know, going to be hard to express, perhaps that's not a use case that you should go for.
Gotcha. Excellent. Michelle?
Yes, I'd just like to add, when we talk about use cases and a phased approach, this is leading into our next discussion item, but it's really focusing around making sure we have the right data, attested, certified, verified data. The use cases will work perfectly fine. But we've got to make sure when we are looking at the use cases and we're doing a phased approach, that we consider other activities, like when an individual practitioner, an MD or DO is going for a certification or a license change. We want to make sure that we have the most current offered use case types, so that we're not planning for just now, we're planning for the future, which would include credentialing, enrollment, any other type of activity, potentially contracting and networking, to where this information is a part of that use case. So again, just want to make sure that, you know, when we talk about use cases, we're talking about today, tomorrow, and beyond, and making sure that we're looking at other activities that are a part of what we consider at Availity the provider life cycle model. So again, this is leading into our next slide that talks about the additional credentialing solutions that potentially are out and available in the industry today, and what we can do with use cases to incorporate that level of data, so that we're not repeating and asking for the same things when we have use cases for credentialing versus enrollment. And then we get to provider directories, because you don't want a provider who hasn't been through the credentialing and enrollment process to get into a directory, right? At the end of the day, we want to make sure that provider has been credentialed, enrolled, and then applied to the directory with the most current recent information, so that the consumer, the beneficiaries, the subscribers, dependents can locate a particular provider.
Excellent. Yeah, thank you for those comments. And why don't we continue, April, if you wanted to take this one as well.
Getting myself off mute there. I think this one is fairly similar actually to the prior question in terms of, you know, other things that should be aligned state and locally with local governments and how they can work to align those policies. So I'm curious if folks have additional comments related to this, but I do think this is very much related to the prior conversation that we just had.
Gotcha. Yeah, and I just wanted to highlight Robert in the chat who says not part of the mandate discussion, but maybe we can find a place to throw a comment in that if they're going to do all of this, it would be nice to align all the various government issued provider identifiers into to one big cross-reference place, for example, the CLIA number to the MPI. So I think a good suggestion to make to CMS that, you know, while they're looking to streamline, why don't you streamline the identifiers as well? So thank you, Robert, for that. Yeah, so I agree with you, April. I think a lot of the discussion we've gone through. So I think we can move to the next slide. So I'm going to again call on April because she might have a perspective on the credentialing issue for this one.
Yeah, so I was actually going to jump on to some of the comments that Michelle had just made. Actually, I think this question is, I think, particularly relevant because there, to Michelle's point, there is a lot of relationship between credentialing in particular and directories. There is a sequence to how that progresses, and actually very similar data elements that can progress through from credentialing in particular to provider directories to limit what is needed to be asked of those providers. But there's also a very unique licensing aspect to this as well within the states and within the provider specific entities around licensing. And so curious folks' thoughts here around the connection between either certification or between credentialing and or licensing, and whether there are some efficiencies here that could be utilized kind of across those use cases, both within the public sector and the private sector, and what might be the role of states in some of these issues.
So maybe I'll ask a question. So the credentialing issue is an interesting one because it's very similar to provider directories in the sense that the need is for health plans to have up-to-date, accurate information for enrolling a provider in their health plan. Is there currently a national credentialing database? I guess I'll ask that question to you, April, first. Is there one out there now?
There is one there now. Our CAQH ProView system does engage with today 2.5 million providers. This includes close to 1 million MDs and DOs, as well as other provider specialties, including dentists, nurse practitioners, physician assistants, chiropractors, kind of all down the line. There's about 50 different provider types that are included in there. And it does support the vast majority of use cases and is required actually in some states.
And I guess my follow-up, and we've got two hands up. I'll get to Tammy and Denny in a second. But I guess my question is, do health plans use this ProView? And are there any health plans in particular that have refused to get involved with this sort of ubiquitous approach to data?
The vast majority of health plans use this. We have over 1,000 different health plans today that are using the data that is in ProView.
Any major health plan that you can think of on the government side, perhaps, that does not?
I would say most of the commercial sector, as well as some of the state-based credentialing uses that information. PACOS, that I think we're all familiar with, is the separate federal system that collects similar information.
Yeah, so I guess that's a question, which is there has been developed a private sector solution, but in particular, CMS has decided not to participate, certainly at the federal level. So I just wanted to point that out, because they're asking for the reverse. They're asking for them to create this database and for the commercial plans to come and invest in their solution. So I think it's important for us to remind CMS that there may be an opportunity to streamline provider reporting on the credentialing side as well as the directory side. But let's go first to Tammy and then to Denny.
Thank you. Yeah, so my comment was on credentialing as well, because I see there's two sides of the coin on credentialing, right? There's one, which is just the provided data. And, from our perspective, like a physician should literally never have to fill out where they went to medical school or where they did their training, because they're authoritative sources for that information. And that's the other side of credentialing, right? So there's the supplied, and then there's the piece where you have to actually go verify all that information, and where there's validated sources to do that. And I think on that latter part, there are a number of utilities out there. So I look at like FSMB has centralized a lot of this for licensing and verifying that data. For the state licensing boards, hospitals, and health systems, we've done some of that, where somebody can pull a profile from us with validated data, so that they don't have to go then verifying and checking all of this information. So I think there are a lot of different solutions that are out there to streamline some of the credentialing and licensing pieces. And then the other thing I would just add there too is remembering too that there are 8 different accreditation standards or accreditation bodies that govern, how that data has to be validated and what has to be validated and who's an official display agent, and all of those things that also needs to be taken into consideration.
Excellent. Thank you. Denny?
Thank you. I think following on Tammy's comments and April's, I think what we see in Massachusetts is we see different payers using different approaches to credentialing. We have licensure at the state level moving on its own track, increasingly improving the quality of information and the digitization of information that is available about providers. But I think one of the helpful ways to think about, and Jay raised this, about a fundamentally federated problem. This is not a problem that centralization can solve without creating additional problems of its own. Mainly that multiple states have different criteria for a range of things that have to do with a physician directory and the associated services or validations or verifications that go along with what a physician directory or a provider directory can support. So I think thinking about this problem as what is it that would save states and the private, not-for-profit, public health plans operating within the states what is it that would save them problems? Because this is information that is consistent, such as, education, verification and validation, the kinds of things that go into a provider provider directory that would be consistent regardless of the state in which the provider practiced. And then there are state-based requirements. And I think if the recommendations to CMS were to include a consideration of what states need to think about and do with the credentialing systems they have to establish standards that are common across all the states, but allow states to manage state-specific information. Otherwise, trying to do that all from a central repository invites, invites huge validation and verification problems. But having that balance between what is it that can be collected centrally, managed centrally, and what is it that needs to be decentralized, federated, and have those two work together so that from the provider's experience, they're updating their directory information, and where that information goes is not relevant. They don't need to know that. They need to know that once they do it, if they do it once, they do it completely. And it's up to CMS and the people informing CMS's decision in this to think about, how does the central federal government and state governments work together with the industry to draw a line between what's federated and what's centralized. Thank you.
Yeah, appreciate that, Danny. And we did have another comment that I think dovetails on that. The question is there a public catalog of state and federal provider data sources? If not, perhaps that is a step one item for CMS to better understand the best pathway forward. And I really like, Danny, your concept of looking at it through two separate lenses. One is what can they capture centrally, and then what can be federated. And I think that's a very strong point for, I think, WEDI to make in our letter. And we also have, okay, I think we can move to the next slide. So with TEFCA, maybe I'll call on Michelle if you want to take this one.
Sorry about that. Yes, absolutely. So for us, understanding exactly what is taking place and where this is going, again, understanding respectfully that TEFCA is a process, and it is, an accreditation, a certification, a requirement, again, for organizations who are interested in becoming that health information network. So our potential WEDI response to this particular ask or questions is really around the evolution of TEFCA and what it presents as an opportunity for everyone in the healthcare industry. That's consumers, that's providers, that's health plans, payers, and vendors, clearinghouses, et cetera, and really better understanding how the exchange of health information is going to take place. Could the NDH be leveraged by each of these stakeholders, again, consumers, providers, health plans, payers, vendors, clearinghouses, to really include that access point? So if you will, getting and putting of data, that pull, that push of information safely. And I say that because, again, we talk about interoperability, we talk about security, information security networks, and making sure the level of data is secured in that environment, and making sure we understand who the individual is sending and receiving the data. So again, that two-step authentication process when an individual is coming in and attesting, if you will, to provider information. So again, understanding that TEFCA is a process, would this benefit the NDH and the stakeholders and really getting that information at a level that we're all comfortable with, and keeping up to date with those regulatory certification requirements on a regular basis. Denny?
Ready?
Unmuting here. I'm not sure that TEFCA is the guidepost that we should necessarily be looking to. I think there's a lot that TEFCA brings to the table around standardizing the exchange among providers. But one, it's voluntary. So there will be a lot of providers who are not going to be using TEFCA, at least in its earlier implementations. Secondly, TEFCA is pretty exclusive. Health plans are not really part of TEFCA. The FHIR roadmap is in development. Consumer access to TEFCA is largely considered is I would say a vision, but it hasn't been operationalized or at least specified in any meaningful way. And we're also seeing an increasing amount of FHIR-based exchange between payers, providers, regulators, and consumers. And if we're going to be looking forward rather than looking back, which I would argue TEFCA looks back and says we have a mess of provider-based exchanges across the country, HIEs that need, a common framework for exchanging data, that need to beef up their roles and their responsibilities. But still, it's looking back. Looking forward, we're seeing an increase on APIs, an increase on reducing the amount of data that is in motion and focusing on data at rest and how to give folks access to the curated sources of data via APIs. So I think, and again, this comes from our perspective, a data perspective. It's not really a policy perspective per se, but TEFCA, even from Marianne Yeager's most recent comments, is a 3 to 5 year proposition before it achieves any meaningful level of market penetration. So I think TEFCA is part of the discussion, but I would be careful about our recommending, and I don't mean to attribute this to Michelle or anyone who is talking about this, but I would be cautious around using TEFCA as a guidance for those reasons.
Thank you, Danny. And I just wanted to reference a comment from Mark at Ed that builds on his earlier point that directories should have entries in the NDH so that these different directories for different purposes can be discovered. I think they that gets into the issue of TEFCA, and I'll put out a potential approach for WEDI here, which is along the lines of TEFCA presents a huge opportunity. However, it's very nascent, and we need more time. TEFCA is not even live yet. We're still a long way away. And so maybe as a use case for the NDH, it's one of those to be examined for the future. And to Ed's earlier point, we should be thinking about sort of the low-hanging fruit opportunities associated with the NDH, not these opportunities that may present themselves years down the road. Let me know in the chat if you think I'm off base on that. But I think Denny summarized that concept very well. So thank you, Denny, for that.
Absolutely. Denny did a great job. Thank you.
And unless I see any other hands on the TEFCA issue, I think we can probably move to the next slide. And that's on data types. And maybe I'll have Kim, if you'd like to take this slide.
Sure. So the types of data that should be publicly accessible certainly is something that I think we all need to look at. So are there data elements that are collected that we should suggest not be made publicly available? And are there others that, we're fine with sharing? And I think that's just the real question from a security and a privacy perspective. I guess from, I don't know if anyone has any specific comments on this one.
Yeah, when you think about the data that might be collected by CMS, what I think about is, I don't know about MPIs, but certainly tax identification numbers, DEA numbers, things like that. I'm not sure that the provider wants those numbers out available to the public. But I'd be interested to hear, I don't know, Tammy or Nancy from the AMA's perspective. I'm guessing you've got some concerns about some proprietary information getting out into the public sphere.
Yep, I'm happy to jump in here. Yes, I think you've got a couple of things. So I like a DEA. So, DOJ has already been systematically clamping down on who has access to that data because they are, prosecuting several fraud cases right now. So, that's one that obviously should not be made public. So we have cases of physicians that are subject to stalking and things of that nature. And we have physicians who have, legitimate reasons for wanting to be able to opt out of some of this information, not have their name changes made public, those kind of things that we need to take into consideration. This also starts to touch on a little bit of the equity pieces, which I think is in the next slide. And I know that's been, well, actually, before I go there, the one other thing on privacy, we also have privacy legislation popping up everywhere. And so like in Colorado, the legislation that goes into place next year for sensitive data, somebody has to opt in to each and every place that data is going to be displayed, opt in to have that displayed. So I think that all needs to be taken into consideration as well. And then with the equity data there too, I think that's a big conversation now, right? Like what a lot of studies on concordance and what that does for outcomes and what data, should and should not be publicly available to help patients. And I think that's a much longer, more robust conversation on, how do you do that to help the patient population without with avoiding some unintended consequences that some of that can bring.
Excellent. Good comments. I've got a question for the group. Well, maybe I'll wait here. Stanley, I see your hand up.
There we go. Okay. I think there's a whole range of data access issues from publicly accessible to thoroughly private or for internal use. Is the data going to be shared with health plans for their internal use? Will providers be happy with that? Where are all of the places that the data will be shared with? Who has access to it? It's not just publicly accessible versus private. I think it's the range and the giving providers some knowledge as to where that data is going to be shared and perhaps some control over who gets each piece of that data. And obviously, it's critical that privacy protections be put in place. That's sort of like what privacy protection should be in place, whether it's opt-in or opt-out, and some registration for who can access the database would be very important.
Thank you, Stanley. My question is, it goes back to our earlier conversation. When you think about what would be helpful for a consumer or a patient, one of the key things would be not just the physician's name, their address, their phone number, but of course, are they in network? Are they participating in a particular health plan? So that gets to our earlier point of, if you don't include that and you can't keep it up to date, is the utility for the patient decreased significantly, and therefore should the patients be directed to the health plan site for more accurate information regarding network status? Michelle?
So to your point, I do think that, we also have to take a look at, is the provider accepting new patients at this particular service location? From an ADA certification, what are those languages spoken at that particular facility or practice? Not just at the physician level, but also at the staff level. So to your point, I think that that level of information should be available in a consumer-facing directory and should be collected at the time that the provider is attesting or updating their provider data. To Tammy's point around the DEA and to your point around the tax ID, those definitely are feedback that we've heard from a provider information subwork group from our large providers. That is something that they do not want shared in any type of consumer-facing directory. So I do know that folks that attend our WEDI provider information support group meetings and specifically around the providers participating, that is something that they have really said they do not want available in a consumer-facing directory.
Excellent. Appreciate that, Michelle. Kim, and then April.
Hi, as far as the consumers go, I think this is that's sort of like the nut of this, where this provider hub, the data hub, is centralized location for that core information about the demographics of a provider, even their office hours and if they're accepting new patients perhaps. But when you get into who can see what patient, the relationship that they have with a health plan, like that to me is really like the centralized hub is a great place to source data and try to keep it up to date, but how it's used and how it gets shown to the consumer really, from my perspective, is more of a health plan job. And that's also where it becomes challenging. You've got all this information in the centralized data hub that you then have to align with how your network is contracted. And that's where the bulk of this gets really complicated to implement from a health plan perspective. But I do look at this as the source of the data versus who's actually displaying it being very different pieces of this puzzle.
Excellent. Thank you, Kim. April?
I was actually going to say some very similar things to what Kim had just said, in that I think an NDH for consumer use raises a lot of challenges and complexity around, because just because a health plan has a provider in their network, that does not necessarily mean that a particular patient and a particular product is able to see that provider or at that particular location versus another location. So it gets very complicated and also I think raises some legal issues, also liability issues related to the No Surprises Act. If the federal databases for consumers and it's not accurate, along with changes that are made in contracting between plans and providers, and a patient goes to a location that they think that they can go to and pay a particular copay, or not even whether they can go there, but what is the level of tier of copay and what is that payment, and it ends up being wrong, who's liable for that? I think that raises a lot of just a lot of challenges to be able to have a centralized federal data source being able to be able to track all that complexity in a timely way.
Great point, and I think it underscores potentially what WEDI may put in our comment letter, which is start small. You can always expand. Keep things simple to begin with. Because if you try to do too much, it's going to open up a lot of complexity and challenges. We do have a provocative question raised, and that is, should the NDH include provider quality scores? I'd be interested to hear from providers in particular. Tammy or Nancy, what do you think about quality scores? Of course, it depends where those scores are coming from, if they're validated, all those things, I'm sure.
Yeah, I was just going to say that. So it depends on the transparency in the score, how it's calculated, who calculated it, if the provider had an opportunity to review it and react to it. I think there's a lot of nuances to that one.
Yep.
This is Nancy. Just to add to that, again, it goes back to, quality measurement is very specific to the use cases that it's developed for. And I believe, I'm not involved in the quality aspects, but there's usually a lot of information, caveats, description that goes along with a score. And so just having a score show up in a directory by itself will not be of any use, I would think, for anyone really in the industry.
Excellent. Thank you both. We did have another comment, I think an important one. In-network status may depend on the specific services sought, and plan benefit. Provider may be in-network only for specific procedures. So I think that's an important component. And again, it really reminds us that moving into the commercial space may be more challenging than CMS anticipates. And Gail writes, provider quality scores that are specific to a payer should not be in the NDH. Perhaps scores from entities like JCO might be more appropriate, but she would still have concerns about that data being in sync with the source and the provider websites directly. So great points. We do have a hand. Rebecca, please share your thoughts.
Oh, there we go. Thank you. Yeah, as far as census goes, I think we are eager to be, included as a provider type, but especially when it comes to provider scores in dentistry, we're really struggling right now to have that well defined. A lot of it is just sort of consumer reporting back, consumer scoring. So when we talk about the phrase quality, it's one of the things that we really struggle with, and we wouldn't be able to support anything like that in this.
Thank you, Rebecca. And I think we've got a good consensus around the idea that we want to make this NDH as helpful as possible for consumers, but we believe there are some limits in terms of the types of data that should be made available to the public, including some of these more sensitive identification numbers. And I think we agree that it's critical to have, privacy protections in place that are up to the highest level of industry standards. Nancy, I see your hand.
Yes, I was just going to add that I think this goes sort of common sense, and many people understand this, but the more you add to something in the way of a directory, the more likely you are to have problems, mistakes. The more focused you can keep it, the better it will be in terms of validity, reliability, all of that.
Yep, excellent. So I think with that, I think we can move to the next question. And supporting health equity, maybe Tammy, I'll have you lead us on this one.
Sure, and do that. And actually, just to add to Nancy's comments, I was just thinking, because as she was saying that, I was just thinking, this whole directory thing was born out of the biggest issue is provider at location being correct. That is what CMS's own audits show. That is the biggest issue. And it's like, it's, you know, it seems like it would make good sense. Like, let's focus on solving that issue. We have a whole lot of surround going on here in this RFI with all the other use cases and questions. So, so that was a good comment, Nancy. Okay, so health equity, the desire to lack going on in health equity these days. And so, you know, with the NDH, there is a desire to support equitable health goals throughout the healthcare system. So what does that mean, and what does that look like? So some of the specific questions, I think, that have been filtered up here is, should an NDH have things, collect information on entities such as food banks, mental health services, transportation assistance, that would be geared towards, I would think, both patients, consumers that are looking for those, depending on if this is a consumer facing tool, as well as I know that we often hear from providers that are looking for, you know, referral services, like what services are available in their areas, where can they refer their patients. So just curious, folks thought, like, you know, what are the important things to support in an NDH from an equity standpoint? I'm seeing one comment in here on some sort of indicator on, you know, ability or knowledge of specific LGBTQ care at a location level. And I know we hear that through some of our equity channels as well. Some of the other things that we hear, I think were mentioned earlier, things like languages spoken, accessibility, all go to equitable. I'm curious on if anybody has thoughts on some of these services, you know, the food banks, the mental health services. Is that a gap that you see today that should be included in an NDH?
And Cheryl writes, race, ethnicity, and language should be included at a minimum. But I'll go ahead, Kim.
Yeah, I mean, I think all of the things that are listed here of different organizations that, you know, maybe not providers, but they're organizations that are supporting patients and members. I think everyone's doing their own thing. I know in Massachusetts, we have one version, maybe every, you know, health plan has their own. So I guess it's a question of, you know, is putting all that information together valuable enough to try to add those organizations into the process, because they're not providers, or many of them aren't providers. They're not used to doing this sort of work. It's not used in quite the same way as your typical provider directory. But I think it's the services that are listed here in this slide are, you know, are the things that we're constantly challenged with trying to collect and maintain and support.
We'll go to April next.
I think, you know, on this particular question, where this appears challenging to me, and we've started some of this work at CAQH, is that there are not standards for a lot of these things, not common definitions. A number of the states have started asking some of these questions related to network adequacy, and they are kind of all over the board in terms of that. So one of the things maybe in this area in terms of a recommendation is, before you start collecting data, try to start creating some standards for at least some of the baseline data, so that it can at least start to be collected consistently, or states can start using some of national standards in some of the requirements that they are putting out.
Excellent. And you've got a couple of points. Chris says health equity should probably be a future goal and part of the design for the future. Let's get the NDH stood up and working first. The main goals, Josh agrees, getting non-traditional providers included will be tough. Getting them to have NPIs for billing has been tough. Jeff, I see you've got your hand raised.
Yeah. Thank you. I was just making sure I was unmuted. I just wanted to add on that last statement that California Medicaid has been pioneering, if you will, the use of the 4050 version of the 274-109 transaction to collect provider data. We've been collecting for managed care plans for 5 or 6 years, and are in the process of adding behavioral health, mental health, and DMC ODS plans as well, providers and so on. Just kind of wanted to throw that out, that we are already applying a national standard to that collection. And I believe there is an updated standard that's in the works at X12 that'll probably, there'll be more information about that out soon. Although I'm not sure, this has never been mandated by national law. So anyway, and Michelle is very familiar with it, Michelle Berry. So again, just wanted to point out California is already doing some provider data collection.
And Jeff, if I can, would you then recommend, for example, we've had discussions about trying to get data feeds from states. Is this a case where it's better to go to the source rather than start from scratch and try to collect the same data?
Yeah, if you mean the source, if you mean us,
Yes.
California Medicaid,
Yeah.
That does make sense. And I don't think I'm not imagining there'd be any issues with being that data source. So yeah, that's a good point. Yeah, I would say probably coming to the source would be better. We have it, or in theory, we will have it.
Okay, excellent. Thank you.
Yeah.
And Michelle?
Yes, just want to say thanks, Jeff. This is also a part of understanding, Rob, to your point, that the source is the entity that has that data, that receives the data specifically around provider information. So state Medicaid, for instance, Medi-Cal in California, they directly have that level of information. So again, understanding they utilize the standard currently today that's in production. That standard has been out and available for many years and has worked really well for a lot of other state Medicaid programs and some other organizations who utilize the X12 version of the provider directory.
Excellent. Tammy?
Yeah, just one other quick comment on the standard. So a little bit different focus. So there is some work being done by OMB, which folks may be aware of, who've started some listening sessions around standardizing values for some of the equity data collection. So race, ethnicity, language proficiency as opposed to language spoken. So there is some focus there. Additionally, like we've been working with the Association of American Medical Colleges and Accreditation Council of Graduate Medical Education. We're all agreeing to use the same collection categorizations for race, ethnicity, sexual orientation, and gender identity, and language proficiency are our first three, so that we can measure consistently across the student, resident, and physician universe some of these, the equity pieces. So just a couple of additional data points.
Appreciate that. I see Mike, you've got your hand up.
Maybe Mike's on mute.
I don't see a Mike with his hand up.
Oh, he just put his hand down. Okay. Mike, if you want to make a comment, please raise your hand again. If not, I think, oh, okay. There you go, Mike.
Oh, there, I'm unmuted. Hey, so we got maybe a little ahead of ourselves. There may be a slide coming up to talk about standards, but I know Jeff and Michelle touched a little bit on standards, and there's definitely a good conversation to be had there, and I can wait if there's an upcoming slide.
Would that, yeah, if you can wait on that, I think we're going to have a very robust discussion on some of their suggestions in terms of standards. But
Okay.
I think, if I can try to summarize, I think we all agreed that there might be significant utility in not just patients having access, but also potentially providers and health plans having access to social services. But numerous hurdles exist to try to get this data. Somebody mentioned that there's not sort of a standardized way. They're not used to reporting this type of data, certainly to CMS. And whenever possible, go out and use third-party data sources to populate this. But I think an overall perspective for WEDI is this is in the category of nice to have and maybe not critical to have right when the NDH is launched. So maybe a future use case as more and more groups become knowledgeable of the database and are more comfortable submitting data. If folks disagree with that summation, please let me know in the chat. But if not, I think we can move to the next slide. So maybe I'll ask Nancy to take the lead on this one. It's one of the more challenging slides, I'll admit.
Oh, Rob, you called on me when I wasn't expecting to
Sorry.
to be speaking today. Do you want to have one of the other facilitators handle this?
I can start, and this is, I think, really, if you think of all the questions, this is one of the ones that is really at the core of their concept, and that is, how could NDH use within the industry be incentivized? And they kind of list out the groups, payers, health systems, and public health entities. So each one, I think, deserves its own discussion. And, we have talked today about how can we get providers to be involved in this, absent, the stick approach, the requiring providers to do this, maybe a condition of participation in Medicare. That's an option for them. Of course, it won't get to all providers, and only those that are actually participating in a Medicare or Medicaid program. But are there some carrots that we can offer? Obviously, for those that participate in Medicare, potentially bonuses, maybe something related to the merit-based incentive payment system, better known as MIPS. But maybe we'll start with the provider side and figure out, are there any incentives that we can come up with that might encourage providers to get involved in the NDH? And maybe I'll call on Tammy first, if you don't mind, just to, are there, obviously, there's a lot of concerns about the stick approach, about requiring any group in healthcare, but we'll start with you, Tammy, and then we'll go to Rebecca.
Yep. So with directories, I would say that providers in their practices, they feel like the group that doesn't have a voice. They're dictated to how they're going to provide the data, what data they're going to provide, how frequently they're going to provide it, and there's little to no consistency across all the organizations asking them for information. So I think the carrot again would be, can you standardize as much as possible? So can there be some consistency in what's being asked for across all of these different entities in a similar format, with similar data definitions and formats and things? And I don't, I'm just a skeptic, but I don't think you're ever going to get to the reporting in one place. So, can you at least minimize the reporting, and can some of the entities that are collecting this information maybe start engaging, sharing, collaborating to start minimizing some of the places that the data is has to be reported. So that would be my feedback.
And I like that idea. The concept of, and again, starting with the government programs, you give the provider two options. One is you can do individual reporting with each of the programs, or you can go to one place and enter your data one time. I would think that might be a significant incentive to get folks to do that. I think the key would be education and communication. So folks understand what's going on and the value of going to that centralized reporting portal. But Rebecca, let's hear from you.
Yeah, I think just reiterating that, especially for dentists, we still are kind of a cottage industry. The people who are going to be the burden on the providers to go in and update this, it's literally on the providers or maybe their hygienists, maybe a front desk staff, but it's very small practices. So the more places that they have to sort of re-enter this information on a recurring basis, the more times they have to do it, it's less time in the office doing the things that they actually want to be doing. So really leveraging where's the data sources that they're already reporting to, and how do we use those to feed that information in. And I get a little bit concerned when we're talking about a stick for requirements for conditions of participation, especially in these very early stages. I think incentives for people to participate is great. That cuts some of that burden down. But then where we talk about, penalizing someone for having out of date information or inaccurate information, things like that, we get worried because we know that it's just going to be a challenge for dentists.
Yep, appreciate that. April, I see your hand.
Just two things I wanted to mention. I wanted to reiterate one of the things I'd mentioned before is that, other than considering carrots and sticks, collecting information from where providers are already engaging and not adding another thing, I think can be an incentive because you're, to Tammy's point, you're just asking them less often. The other thing that could be considered as well is, I'll reiterate one of the points Rebecca made, is that if there are places that providers are currently providing information and they're validating and verifying that, if CMS would allow the providers to designate from those organizations to submit information to this source so that the providers they have a choice of whether they want to go in themselves or have another source submit for them, that could also reduce burden for providers.
Yeah, great points. And Michelle?
Yeah, let me just add another stakeholder here would be vendor and clearinghouses. So I think that vendors and clearinghouses also should be considered in this approach or process. And Rob and team, you've heard me say during our WEDI provider information subwork group, carrot sticks, right? We can go to the grocery store and there's carrot sticks. So at the end of the day, the opportunity is to really drive fraud, waste, and abuse down, right? To drive the medical costs down, interoperability up, and incentivize folks to find the provider at the right time, especially around, GFE, the good faith estimate. Provider data is critical in getting that correct. And again, understanding that that is an incentive, right? To make sure that all the information is documented, making sure that the patient is able to choose which facility to have outpatient hip replacement, so an elective surgery. So again, understanding respectfully, I think we need to include clearinghouses and vendors here as stakeholders, and we really need to incentivize everyone to understand that there are carrot sticks literally in this process. And how we do it is communicating accurate data, making sure the right entity is receiving that information. So again, if we can, Rob, to include clearinghouses and vendors in this response, it would be great.
So Michelle, you're suggesting that both vendors and clearinghouses have a vested interest in accessing the data stored in the NDH, and or are you thinking more of a data exchange approach?
So both, right?
Both, okay.
Data exchange is critical, and your vendors and clearinghouses understand data. They aggregate data. They are able to report on specifics, whether it's CPT, ICD-10. Vendors have different levels of data. So again, I do think that, both would suit the clearinghouses and vendors. So I would suggest both.
Okay, excellent. So let's switch gears and talk about health plans. Obviously, for those that are under the regulatory authority of CMS, it can be a stick. They can require that. But for those that are not, we've talked a little about some of the challenges that plans will face. Are there some opportunities, though? For example, just if you play this out, if a health plan can scoop up data from the NDH that meets 90% of their needs, and so their reach out to the provider is minimized, that might be valuable for both the health plan and the provider. And assuming that, what are some of the carrots that we could offer the health plan to get them to be engaged? And maybe I'll ask Kim to weigh in on this. So what would convince you to go to the NDH for provider data?
Knowing that I could get, accurate quality data that I'm not going to have to chase other providers for. And then if there's an actual reduction in the administrative burden that we have at the health plan to manually maintain all of that data or manually validate it, that would be, sort of the ROI overall would probably be the biggest piece there.
Excellent, excellent. Others from the plan community, if they want to weigh in on this. Well, you're formulating your thoughts. Let me throw out another concept. If, and again, all this is future tense, should the government come out with an enforcement arm based off of the No Surprises Act requirements in the directory area for health plans, would there be potentially a safe harbor? So if a health plan accessed NDH data, that they would be held harmless for any errors included in that data. Is that something that would be any kind of incentive for health plans? Kim, I'll put you back on the spot here.
Yeah, no, I mean, I think it would. I mean, there's, yes, I mean, the knowing that if we're doing everything we can, we're using the source of truth. And I think that's what this all really comes down to. Are we agreeing that this is true, the true source of truth? And if we can take that as valid, then that's a huge win.
Okay, good. Others want to weigh in on this? Jay? Yep.
Sorry about the mute thing here. Just to add a little bit to it, from a plan perspective, the contracting process and also providers as well is pretty onerous. Certainly there's some help with, credentialing through CAQH as an example and some other things, but there's still a lot that needs to be done and a lot of data collection. So if there's data captured within the NDH concept that could be shared with plans that would make that contracting process more efficient and less burdensome for both providers and payers, I think that would be an incentive.
Appreciate that, Jay. Tammy?
I have what might be too tactical of a question, but so Kim, I like you said, this is the source of truth. And before that, you had said like one of the carrots would be if you knew you could get good quality data. So I just wonder, and then to Jay's just comment too, is there like what specific data would need to be or what specific data would you look to NDH to be able to pull from? So are there like 4 or 5 things that are super difficult that it's like, gosh, if they had those and they were good, that'd be great?
That's a tough question. I mean, and this is one of the most challenging is I think we're not often notified that a provider has left or joined a new practice. And then of course there's other work we need to do, but that their address has changed, that sort of thing. So I off the top of my head, I can't think of exactly what that would be.
No, that's helpful because I think that, I'm kind of going back to what I was thinking earlier, that the biggest problem seems to still be provider allocation. So if there was a place to report that somebody had moved, they're no longer with this practice, like that would be of benefit to the industry.
Agreed.
And again, I think that raises the issue of, the higher the quality of the data, the more accurate, I think, therefore, it's going to be a greater incentive for everybody to get involved with it, but not least of all health plans. And it's all based on the quality of the data. I think that's certainly something I'm hearing. It says perhaps being an NDH data partner could be an input for Medicare star ratings. I think that's very interesting. I like that. Gail says, I would not assume that payers could just update their provider data stores based on such changes in a database like NDH without additional effort and potentially verification with the provider. I think that's a critical point that, what's the old saying, trust but verify. So especially if you want as accurate a directory as possible, you may see the NDH as a starting point, but you may not feel comfortable with that being an endpoint. So very important. Other thoughts on health plan incentives? I think what I'm hearing is the better the data, the more of an incentive it will be. The point is made that if you had specific data points that were particularly troublesome for health plans, if they could be included, for example, provider location, or if a provider has left, that would be an incentive, potentially a safe harbor. What about if WEDI recommended that they conduct an ROI study, maybe through a pilot with a health plan, to show the value of accessing the data compared to the proprietary approach, and made that information publicly accessible? Would that serve as an incentive?
I think anytime you can show a pilot and actual results, that's definitely a positive to get other people engaged.
Okay, great. Unless we have other issues on plan incentives, let's spend a couple of minutes talking about public health entities. Oh, let's hold on. We do have a Rebecca says, will there need to be considerations for different provider types? I'm not sure all data needed for one type of provider is going to align or be appropriate to others. Do we have a good understanding of the minimum data requirements for what should be included to make the NDH viable? I think very good point. Switching gears to public health, I guess in my mind, there's sort of two buckets. One are those under the general umbrella of the government, including HHS. I think those entities can be required, but in particular on the state level, where they may not have the same type of stick approach. In particular, we got the question: would would these state governments, the departments of insurance, would they get engaged voluntarily? So I'll pose that, and maybe have Tammy, if you want to weigh in on this one.
Sorry, Rob, which one?
Yeah, so we're really asking about state government, and in particular public health and departments of insurance. How could we get those folks to get engaged? Obviously, you can't force them unless there was some federal law, which I don't think exists. So how could we get them engaged voluntarily?
So that's an interesting question. And I actually go to, like, what would we want from them? So they certainly collect some data, right? But, like if I look at a licensing board in a state, the data that they're collecting isn't going to contribute really to a directory outside of somebody being licensed in a state. So I don't know that I have a good answer for this. Other folks have thoughts on state government and what the NDH could gain from them and how to get them to participate.
And is this a case back to our staging approach, where it's a nice to have, not requirement out of the blocks? Again, it's going to take a lot of buy-in to get states to participate in an NDH. And of course, each state is unique. Each state may have a particular perspective on the federal government. And so I think getting them to be engaged voluntarily is probably a good starting point. And then you hope that if the states see value in that relationship, then that is a driving force to get other states to get involved. So last opportunity to weigh in on this. If not, I think we can go to the next slide.
You have lots of hands up, Rob.
Oh, sorry.
April, Kim, Stan,
Oh,
Lee, David. Yeah.
Oh, okay. All right. Sorry about that. Okay, we'll go April, Kim, Stanley, and then David. Go ahead, April.
So I'm actually going to put my state hat on, being a state official for more than a decade of my life. Particularly state governments and departments of insurance, there is a general appreciation of standards and wanting to do things in one standardized way. But on top of that, there are a number of unique state desires, requirements that come from the state legislatures, that come from the provider associations, from the plan associations, of just addressing unique state interests. And I remember back to when the ACA was getting debated and passed, and they wanted to create a national exchange that would take some authorities away from the state departments of insurance. And there was a lot of pushback related to that, and reason why we have state exchanges. And so I think, there's definitely a receptivity to some level of standardization, but there's also a lot of desire to be able to address state specific needs. And so I think the main challenge here would be, you could agree on a certain base level of standards, but there are different things related to network adequacy, for example, related to requirements for providers, licensure, those types of things that I think would be very much a challenge to get alignment across everything across states.
Excellent. Thank you, April. And we'll go Stanley, then David, then Bob.
Hi, the CDC is responsible for a lot of public health reporting and working with these public health agencies. It might be worthwhile to coordinate with them to see what data they collect and how it could be contributed to this national provider database. So I think CMS needs to reach out to some of their sister agencies.
No, fantastic suggestion. And that falls in line with, I think, a comment earlier where, we need to, CMS needs to get a lay of the land to see where the data sources are, where's the value of that sort of harmonization. And I think this public health and state government issue, I think falls under that. So I appreciate that, Stanley. We'll go David and then Bob.
Thanks, Rob. This is Dave Howard. And I actually work for the Minnesota Department of Health. And so I'll try to put that hat on, or those lenses on, as I respond to this. The top part of the question in italics talks about public health entities, and yet the conversation is switched over pretty quickly to insurance departments. Those, in at least our state, are two different organizations with two different types of focus and responsibilities and outlooks. I don't agree with anything that's been said previously, especially about the cross currents that state governments face. But I think, when we think about creating incentives for participation, states, including public health entities and public health agencies, are oftentimes really involved in state health reforms. And costs, of course, are a major issue. And one of the issues that has really come to the fore and has really created a reason for discussing a national provider directory are the unnecessary costs and administrative costs of what we have in place now. So I think finding greater evidence of some cost savings, Rob, your suggestion about looking at the return on investment is going to be really important. Using this as a cost containment tool to address really unnecessary administrative costs, I think, is going to resonate in a lot of parts of state agencies. Also, from a public health perspective, I don't disagree with the idea of a phased approach and the fact that we may not be able to get to some of the SDOH objectives as soon as we'd like. But from a public health standpoint, those are going to be very, very important incentives to create advocacy for something like this NDH. If we can show that we're really heading toward a better resolution of gathering and using data to meet public health needs and SDOH, that's going to receive a lot of support from a number of quarters within state government and also from a number of stakeholders.
Excellent points, Dave. Can I push you a little bit? Would you be supportive of WEDI suggesting looking for reciprocity opportunities where the state can provide the feds data and vice versa?
Rob, I think that's an excellent suggestion. I think that's something certainly to be considered and really to be explored further. I agree. Sure.
Appreciate that. And Bob, thanks for joining. I see your hand up.
Yeah, sorry, I'm running late. I have other obligations. When we did the work with FAST around the directory, the carrots and sticks were part of the conversation that we had socialized with broader audience on our public calls. For consideration, carrots, we focused on how we get organizations to participate, in particular individual providers and provider organizations and payers, and also how we deal with at some point the sticks of how you make it work. And I agree with David on the thought that having a verified source of information, a tested and verified source of information, is a huge cost savings for most people that are trying to maintain directories. In fact, it was the reason we did this work. It came out of a meeting we had out at MITRE back in 2015. and I think WEDI participated in that. But the carrots were focused on if you participate and you're a provider, this should be the only place that somebody who wants your information can go to get it. You should not have an obligation to provide it to anyone else, assuming that information is in the directory. So the carrot is you reduce the number of organizations you have to provide information to from 17 to 20 down to 1. On the stick side, at some point, at least for those things that where government has control or at least has influence, so the federal programs, Medicare Advantage, Medicaid Advantage, HMO or Medicaid HMO, CHIP, etc. They could basically say, you can't participate in these unless you are listed here and keep your data up to date. So there's some very large carrots and sticks. On the public health side, having the CDC on board, and this is how it's supposed to be done, and making it available, whether through the CDC or directly from CMS, would be a huge carrot for all of the public health agencies.
So, Bob, let me just push you a little bit on that, because I think I like the approach of again, saying to a provider, a condition of participation in these federal programs is you report through NDH. But other than those types of entities, how do, what's a way for incentives to be developed for those that don't fall under the regulatory authority of CMS?
Well, it depends upon where you go with this. If you think about it, over 80% of all provider organizations, individual providers, participate in federal programs. So you're already at the 80% bar. The question is, how do you do the balance? That's the more complex one. The conversations we had with a lot of the payers at the time said, if we implement this for public programs, we'll implement this for commercial programs. We don't want two methods. So that may be the way it happens, is payers just say, that's it. We're doing it this way. If you want to play with us, go register here.
Gotcha. Okay. And I think, to your point about sort of the remaining 20%, a lot of those perhaps are, and we're lucky to have Rebecca on the line. They could be from the dental world. And maybe one of the incentives is to work directly with groups like the ADA and say, hey, communicate out the value prop of working with the NDH. And maybe, again, working through professional societies to reach as many of that 20% as possible. So I think,
well, I think our biggest issue is going to be around social care. If we're going to include that in this directory at some point, whether phase 1, phase 2, phase 3, how do you incent social care organizations to participate? And that may come from the reliance, at least a large number of them, on federal state grants.
Yeah.
So, that can be like a condition of participation process.
Excellent. Thank you, Bob. I don't see any other hands up, so I think we can move to the next question. And I know we've got some of our facilitators having to drop off, but so it'll be a smaller group, but let's continue on. So maybe I'll have Michelle walk us through the issue of how do you evaluate whether or not the NDH is actually successful.
Yeah, Rob, so this is where, they're looking at how to report. What does that look like? To what level of reporting capabilities are going to be made available? And again, if I am looking at our response from a WEDI perspective, is we really want the stakeholders to be involved in this regular review, looking at the targets, looking at the impacts, and driving opportunities for change. And again, understanding this is for us to have a discussion about, but from a WEDI perspective, our response is really to drive that interaction, that engagement, reduce burden for the providers, first and foremost. We know that they're burdened today. This is not news, new news, if you will, in updating their data. To Bob's point, I think Bob had stated just a few minutes ago, you know, providers have to enter their data in multiple locations or updating their data in multiple locations. Having an opportunity for the provider, and Rob, you stated this earlier, to enter their data once and for one location that services opportunities to push the data, or for entities to come and get that data from an infrastructure like the NDH. So again, understanding respectfully that we want a location where it's consumer, not consumer, provider friendly. Also, if the clearinghouses and vendors are pushing the data to the NDH so that the data is made available you know, immediately. I think, Gail, you had made mention earlier in the conversation about having that data made available, and, you know, again, comparing it to the provider's website and having the data, you know, available and that location as well, so that there's an opportunity for the consumer to see that information. But we've got to track and trend. We've got to look at the return on the investment, look at what is being spent on the investment, looking at other opportunities to potentially have a data governance team that will oversee the opportunity to maintain and keep the integrity of the infrastructure where it needs to be. I know that that got lost in some of our discussion, but just wanted to resurface that here because again, I think that should be a part of our RFI response when we talk about the return on the investment, is having that data governance organization or entity looking at information on a consistent basis instead of it just going to you know, an annual review process, if you will. And I'm just using that as an example. I don't think that would be our recommendation. And also leveraging the health plans and others like us to participate in the return on the investment, looking at that incentivized opportunity for all participating entities, whether it's a health plan payer, whether it's a vendor clearinghouse. And again, just wanting to make sure that we consistently understand that that is our recommendation. April, I think you have your hand raised.
Yes, I wanted to make one comment on this before I unfortunately have to get off of this call. But my comment is actually related to the prior one, related to incentives, and this one combined. I think honestly, one of the biggest incentives for any organization to participate in the NDH is for there to be routine and regular evaluation of the accuracy and timeliness of the information. And that we should start with a minimum number of data elements. And I'll go back to Tammy's comment. I think location is the biggest issue that there is. And you know, there's a lot of I think distrust in NPES because that data is not accurate. And so, you know, I think the biggest thing to garner trust is to routinely be evaluating the data for accuracy and timeliness, and that would be the largest incentive.
Excellent. And April, thank you very much for your contributions today, and good luck with your meeting. Can I also add here, I think I'm hearing some really good consensus around the idea that you know, you have to continually check the accuracy and the validity of the data, and that itself is going to serve as an incentive. Would it be fair for us to also comment to CMS to work with for example, trade associations representing health plans and providers and consumers to make sure that not only is the data being validated, but that the success of the NDH is being communicated, and also provide some opportunities for feedback from these groups. Because again, my feeling is this should be almost like a living document, that it should be under continuous improvement to make sure that it's addressing the needs of the stakeholders. Bob?
Yeah, let me, and it's too bad I wasn't here at the beginning. Let me do a couple of things. In the work we're doing, we're calling out 3 different stages of information validity. One is the attestation by whoever it is that is impacted by it. You know, I as a practitioner, my education, my language is spoken, my license to practice, etc. Second one is validation, and we've chosen to use the term validation to mean it meets the standard criteria. So it passes the test of it can be expressed in fire. Okay, so we have valid value sets, we have valid information there, we have all of the required fields populated. That's validation. Verification we're using in 2 different ways. One, verification is against primary source. So if you claim you graduated from the University of Michigan Medical School, we verify that indeed you did graduate from the University of Michigan Medical School. If you claim that you have a license to practice internal medicine in the state of Nebraska, we verify that you do that. The other thing is relationships. We use something we call mutual verification or mutual attestation. So if you claim you have admitting privileges as a physician at St. Joe Hospital in Kansas City, they have to claim that too. Otherwise, it is an unverified relationship. But if both of you claim that's true, we have no reason to say it's not. The other piece of this is there is something called a verification resource or profile that you can get with any piece of data that tells you who attested to it, when they did, how they did, whether it's verified, if it was verified, how it was verified, when it was last verified, and when it will be verified again. So when you get data out of, if they follow the standards we're creating, if they get data out of a national healthcare directory, you will be able to tell the last time every piece of information that is intended to be verified was verified. Does that make sense?
It does. Yep. No, that's
so as long as they implement the standards that we've created, you'll have a set of information that while not everything will be verified and not everything will be verified yesterday, you'll know exactly when it happened and what happened.
I like those verification stages, Bob. Thanks for outlining them. I think we've got enough here. I think we can move to the next slide. All right, and maybe Tammy, I'll have you take lead on this one.
Sure, we're happy to. So, and I think I peeked ahead. I think we've covered a lot of this, right? So I think the questions in the RFI are, you know, as the NDH has been described, would it benefit industry? As described, does it reduce submission burden on providers? And as described, you know, would it, how could the centralized digital contact be benefit for providers and payers? So, and I think of a lot of what we've heard, at least for the first 2 questions, is maybe impartially, depends on how good the data is. I think we've also heard that there are a lot of nuances where, you know, the specialty and the practice location are different based on what payer they're contracted with. So you're still going to have a lot of that individual outreach. So I think that my assessment of what we've heard today is for at least the first two questions are maybe and partially. We haven't spent a ton of time on the third question on the, how could a centralized source of digital contact information benefit providers and payers as described in the RFI. So maybe this is the point to have some conversation on that. I would say the only comments that we hear there is that most providers don't know they have digital contact information, don't know what their endpoints are, that they're really relying on a lot of EHRs for that. And I think you see that in action in NPI where, they've asked providers to update their digital contact information, and we're seeing a lot of @Gmail accounts. Thoughts, questions from, or comments from folks on these specific questions from the RFI?
Maybe I'll start on that third one. I'm thinking of a couple of potential use cases that might be valuable. One is, for example, if the digital contact information was either the FHIR endpoint or the direct email address. For example, with the ADT, the admit discharge transfer requirement, it would allow hospitals to send that information relatively easily to the providers, in particular the primary care physicians. And then if that information was available, the digital contact information, and I'll ask a question of the payers, would it be helpful, for example, in value-based care arrangements where the plan, is able to send information very quickly and accurately to the provider, perhaps letting them know that a patient has presented some other place and allows the primary care doc to follow up. Again, all with the idea of coordinating care, better care management, which would support the value-based care arrangement. So I'll throw those two use cases out to see if they're ones that we may want to include in our comments. And Tammy, maybe I'll start with you on the ADT side. I know that's a huge opportunity in terms of a data flow, in particular to primary care docs. Is there some value there to standardizing that process?
I'm actually going to ask Nancy if she has anything to add there. Nancy's not there.
And Gail says still need to include HIPAA privacy caveat with digital contact information if patient data is shared. Absolutely right. And I think that that's an important point overall, that we're talking about PHI, protected health information. And so it has to fall under the rubric of HIPAA privacy and security. So it's an important reminder. But other thoughts, Dave? I see your hand up.
There, now I'm unmuted. To this last bullet point, the third bullet point that you've been talking a little bit about, Rob, I think earlier in the conversation, somebody paraphrased or used their own version of the Wayne Gretzky quote that he skates to where the puck is going to be, not where it was. I see that as really applying here on this issue of a centralized source of digital contact information. We can really anticipate, I think, a proliferation of providers here in Minnesota to address provider shortages and workforce shortages, especially in some rural and underserved areas. For example, there was a new specialty or a new provider category of dental therapist created. I'm expecting we're going to see a proliferation of new healthcare providers and endpoints, and thinking ahead to that, especially if we start thinking about social determinants of health and including social service providers and so forth, really thinking ahead to that kind of world and anticipating the need for some kind of centralized source for digital contact information is going to be really important. and I think really timely. As for the other first two bullets on this slide, I think what I take away from this is that we've had a lot of discussion about being practical, about maybe abiding by the 80-20 rule instead of trying to reach perfection instantly. I think it's going to be important to remind ourselves and CMS as well that even if we can get to the 80% rule, that's a tremendous improvement over what we hear sometimes as being, 40% error rates in what we currently have.
Yeah.
So I would think that there are tremendous benefits from pursuing this concept. A lot of unanswered questions, a lot of details to be figured out. It's certainly going to be a heavy lift, but I think really certainly worth the effort.
Excellent. Bob, we'll give you the last word on this slide.
Okay. I'm going to go top down. The intent of this had been to ensure that let me back up. In the meeting we had at MITRE, the single biggest issue from everyone, and there were 170 different organizations, half of them were on site and half of them virtually. The single biggest issue that everyone has was quality of data. Single biggest issue across the board. That's why we created this process to get standardization and look at a national directory. There was little question that the ability to have a provider attest one place and one place only made huge sense, both in quality of data and reducing burden. So there's little doubt if this is implemented fully, we will reduce burden and get tremendous benefit. It also addressed the second question about directory submission, because the goal of it was you attest one place and one place only. You don't do it multiple places. So that would remove anywhere from 16 to 19 different organizations you attest to multiple times a year. Contact information. I've been involved with CMS's approach in INPES since it started. The problem with INPES is you're asked to provide it. There is no verification that it's real. In fact, we just went back and pulled all of the fire endpoints from INPES, and about half of them have absolutely nothing to do with a fire endpoint. The endpoint address could be Gloria or Pay or something else that has no meaning whatsoever. There's a set of them that are right, which are HTTPS : anyway. But if we verify them as they come in, first validate that they're correct in structure and verify them against whoever issued it, we raise the bar tremendously. And we get to take advantage of things like Lantern, which collects information from EHRs, Direct Trust, which has the information from the HISP. So I see the ability to get quality information in front of everybody that needs it as one of the key benefits of creating a national directory.
Excellent. I appreciate that. So we are going to move a little faster. I think we've talked a lot that I think some of the points will apply to some of the questions we'll deal with. So Michael, we'll just move to the next slide. So we'll be quick about this one. I think one of the things we've talked about is, start with the low-hanging fruit first, move on to the folks that are generally speaking not required to report their information. That would be sort of second tier. But is it fair to say that however many providers we can get involved in the NDH would be positive? Anybody not agree? Should we be limiting? And we'll start certainly with the providers, and then we'll talk about suppliers and health information networks. But anybody disagree with us suggesting that it would be a positive contribution to the NDH to have these allied health professionals included? Not seeing any in the chat. Oh, okay. Yeah, good point from Stanley. Need to distinguish between individuals and organizations. Very important. And what about, for example, DME suppliers, health information networks, health information exchanges? Is this again in the nice to have and in the future category? Jeff says include community health workers. Okay. Other comments on this one? All right, not seeing any. Okay, let's, go ahead, Bob.
All right, let me make sure that we understand the scope of what we were asked to do. The directory was designed, at least from the standards point of view, with the intent to support everyone associated with healthcare, other than the individual as a patient or the individual as a personal caregiver, not a licensed caregiver. Everyone else was within scope. So the question becomes when you include them, not if the concept already included them.
I think a perfect way to phrase that. So it's, again, maybe we talk about a staged approach. So it's not an if, it's a when. I think that's a good point. I think we go to the next slide. We've talked about this one a little bit. We'll just maybe we'll move to the poll because we talked about some of the value points. Oh, and Rebecca notes physician is defined both in statute and the Medicare manual to include doctors of dental surgery and dental medicine as well. Thank you for pointing that out. So let's go to this because it's I think an interesting question to ask the group. Should a provider's telehealth capabilities be included in the NDH? So we'll open it up for comments. Jeff says yes. Okay. So we've got a majority saying yes, but a number are saying unsure. Maybe the suggestion would be make that a voluntary data point. Stanley?
Yeah, I think this is something that could change and would depend a lot on the particular services and such. I don't think this is a necessity for a directory at this point. Because of its variability and exactly what do they mean by telehealth. Some are phones, some are audio only, some are audio and video, some are only for certain services or only certain providers in the practice. This is I think a tough question to be included, a tough thing to be included in a directory.
Gotcha. Yeah, there's no question there's a lot of variability, but as Kate says, just read a study that found that 91% of people more likely to choose a doctor who has telehealth capabilities. Gail writes, capability is very different from what a patient's benefit supports, and showing only capability can send the wrong message to patients. A very good point. So it kind of reflects back to a point we made earlier, which is maybe the source of truth for something like telehealth benefits is the health plan itself, not necessarily the NDH. And then Jeff says, Stanley makes good points, but this seems to be an important element for patients. Scott says CMS issues a ruling to qualified health plans that required them to report providers' ability to provide telehealth services for all providers published in the directory. So it looks like there may be a precedent for trying to ask these questions, but we can raise Stanley's point of, it's not as simple as just saying a yes or no. There may be other issues as well, including what Gail says. It's network-based, not per provider. So very good. Bob, you've got a quick comment on this?
If I can unmute, yeah. One of the things that FAST decided to do in its response is to suggest that as it was designed, the national directory should include payer provider networks. And that creates the relationship between provider organizations and payer networks. And at that point, you can actually do searching across payers when you're doing discovery of a plan you wish to use, et cetera. You can also wind up constraining the individual's services based on the particular network they're participating in. So we're recommending that they start with those plans that are supported by CMS. So again, Medicare Advantage, Medicaid, HMO, CHIP, and the QHP in the federal marketplace. And then we'll see how we do there and expand out from that point into commercial plans. I just wanted you to be aware of that.
Yeah, appreciate that. So now we're getting into questions of use cases. And we've talked about a number of those. Obviously, referrals are a sort of a common one that is discussed in the RFI. But I wanted to raise, we haven't talked about too much about the technology. So they have the question, beyond using FHIR APIs, what strategic approaches should be taken to ensure that the directory data are interoperable? Anybody? Rebecca, I see you've got your hand up.
Sure. I'm always happy to talk about FHIR endpoints in dental and the fact that there just aren't any, or they're very limited. When we talk about where the data source is going to be, sort of where this information is going to come from, electronic dental records are not prepared to be able to submit the information. So what we would, if I could extrapolate into the future, if this becomes required for dentists, and it's going to be an extra burden on dentists, they're going to wind up having to pay for a subscription service that is going to help them do it out of their EHR. So really thinking about having some sort of authorized data source where they could opt in to say, hey, this is who I choose to be my source of truth for submitting my data. And it doesn't necessarily have to come from an EHR, because we just know that it's just not viable right now for dentists to rely on FHIR APIs.
Gotcha. Excellent. Mike, I see your hand up.
Yeah, I just, I'm going to put this something in the chat as well, but wanted to talk about the actual standard that was named in the RFI. And I know Bob is on and maybe he can expand on this, but, let me see if I can get this typed in there. Not working. Now my cut and paste is not working, so I can't paste it in. But basically, the validated healthcare directory implementation guide is what was named in the RFI, and that, as of 2018, September 2018, it's listed as a continuous integration build STU1 status, which is work in progress, version 0.2, second ballot. And so, maybe there's been some work. I know I did see that there was an attempt to do a FHIR release 4 build of that IG, but that had produced some errors. So maybe there's some additional work that's being done on that implementation guide, but it definitely looks like it's still a work in progress. And obviously there's been a lot of work in the Da Vinci project to do the PDEX PlanNet IG, which is used by the Veterans Administration. It is kind of in production status, and that's based conceptually on the VHDIR IG that was referenced in the RFI. And as Jeff said earlier, I think Michelle also commented, the X12 Healthcare Provider Directory IG 274 was published back in June of 2003. So that's been out there a long time as version 4050, but it was not a names transaction under HIPAA. It has since been updated and published as version 8020 in last year. And obviously that's production status used in the state of California pretty extensively, not just with Medi-Cal, state Medicaid, but also I think Blue Shield, California, as well as maybe some other payers in California as well. And it could be obviously used elsewhere, but those are the ones I'm aware of. And
Excellent.
related to that, 274 transaction, there's also a new transaction, the Healthcare Provider Information IG, the X253, which was published in 2020 under version 8010. And I'll also mention that Fire Argonaut had created a provider directory IG based on Fire Release 3. I'm not sure what the status is on that. And IHE has also produced a couple of specifications around provider directories. So there's a lot of solutions standards-based solutions out there. And the one they're referencing seems to be very much a work in progress.
Gotcha. Very helpful. And Cheryl agrees and says we do need to standardize on fire and implementation guide versions, or at least the number of versions we would be required to support. So great comments. We're going to move ahead. Michael, if you don't mind, we may be skipping here a couple. Yeah, let's skip this one. We've talked about public health. We've talked about health plan participation. Let's go to the poll, because I think the poll is very important. Question, rate the likelihood that commercial health plans will voluntarily eliminate proprietary provider directory data collection processes and access data via the NDH. So we're seeing definitely skewed towards the not very likely or highly unlikely. And again, I think it's not to say they wouldn't get some data from it, but it's unlikely that they would replace their current process with the NDH. So I think that's very good. So we can close that poll and keep moving forward. Thank you very much for sharing your thoughts on that. Fraud, waste, and abuse. I think we can skip this. We talked a little about how it would do. Let's see. We can skip this one as well. So we're going to have to move a little bit quickly through here. And we've talked about, let's talk about this one briefly. I think really I'm interested in hearing in particular from health plans, what the challenges and providers, what are the challenges that we can identify with the current approach to provider directories. I think we talked about some in particular, the location where the provider is practicing. I think things done well. I think I've heard that some of the online capabilities are pretty sophisticated with a number of the health plans. A lot of them do capture languages spoken and provider address and phone number. Any other things you wanted to add, whether it's done well or perhaps need a little bit of work that we don't have listed here? Tammy, anything that you wanted to add in terms of either things that are done well or challenges that we haven't discussed so far?
No, I don't think so. I think I can't think of anything that hasn't been brought up already.
Okay, Bob's got the services available. I think that's an important one to add as well. Okay, great. Oh, and Jeff says California is collecting languages spoken. As far as I know, it has worked well. Currently, we are involved in using ArcGIS to map that data, but challenges in location accuracy. So Languages spoken, I think, is an important one. I think that that's accurate. But somebody mentioned earlier, it's not just the physician who language, but also the staff. So if the staff can accommodate somebody coming in speaking a language other than English, that might be something to capture as well. Michael, I think we can go to the next slide. We'll just really briefly on this. Again, we've talked a little about making the interface as easy as possible, as again, another incentive for providers to enter their data. So ease of use, permitting pause and restart rather than starting over, permitting batch uploads. Anything else, Tammy, you wanted to add? Any other ways that we can make it easier for the reporter?
No, I mean, not other than what we've already said, is just back to the, collection interfaces, back to as much standardization as possible. So
Yeah,
nothing
excellent.
else new there.
Okay, we'll go to Michelle and then Stanley.
Hey, thanks, Rob. When I was speaking of languages spoken by the office staff and the practitioner, the physician, we have seen and heard in our provider information support group that that is critical, and having that level of information. Again, collecting it, the 274 has been collecting that data at the staff level. So again, all the way back to the earliest versions of the implementation guide for the 274. So that level of information continues to be something that is really important. And again, collecting it at the staff level is important.
Appreciate that. Yeah, great point. Stanley?
Yeah, I think we want to mention the ability for a vendor or a clearinghouse or other organization to do it in a batch upload or an upload for a variety of different providers. I think you need to have that representative capability. It doesn't necessarily have to be the provider or the provider's office. The other item is, and it just slipped my mind. Sorry, it just slipped my mind, but I think that was the key one, to allow others. Oh yeah,
Yes.
The other item would be some sort of a reminder or a verification reminder that once a month or once every 6 weeks, something comes back to the submitter of the information that says, just want to verify that this is still correct. I think that capability could go a long way to making sure people are updating their provider information.
Excellent. Good points. Michael, I think we can move forward. Yeah, we talked about this. We can go to the next slide. Michael, yeah, you can move to the next one. I think we've talked about that one. Yeah, so now we're going to do a poll on how often we need to update. We've got 2 questions, so we'll go to the first one. What's the optimum frequency of the NDH requiring provider updates? And we've got these options. So how often should providers be required to go in and update their data? It's an important one. So we've got monthly and quarterly. Luckily, no one put in daily. That's good. Bob, go ahead if you want to comment on this.
Yeah, this is unfortunately something other than a single answer. If I'm trying to verify the currency of a license, I may do that on a daily basis, or I may have them pushed to me anytime it gets updated. This question should be related to attested information only, not verified information.
Okay,
And the reason I say that is if you say you speak German, fine. If you say you are accepting patients, fine, update it monthly or whatever. But if it's something I'm going to verify against a primary source, I'll either do it once for something like graduating from medical school, or I'm going to do it far more frequently for something that really matters, like has your license been revoked?
good point. I think,
So this is not a one and done, unfortunately.
yeah, no, I see that. And then Mike raised an issue. I think that will be addressed in our next poll, if you can pull that one up, Michael. So the first one was related to the provider making the updates. And then the question is, we expect the NDH itself to go through updates, and how often should they change the data set to reflect whether it could be a legislative regulatory mandate or some other. So that's the question. How often should the data set change? And we're seeing quarterly and yearly. Yeah, so we're seeing some good chat on this as well.
So here's a item to consider. If there are 5,000 downstream directories depending upon this data, you don't want to change the data set very often.
Yeah. Yep. All right, so looks like we're kind of split between yearly and quarterly. So I think we can you could say it should be updated at a minimum yearly and potentially more often. So I think that's probably the way we would handle that. So I think, Michael, we can go to the next slide. And I think we've talked about this one. I think we can go to the next one, Michael. So we'll really quick here. We talked a little about delegating to a vendor. There's also delegation for individuals. So for example, a large group practice might delegate Bob or Sally to be in charge of updating all of the provider information. This is a very common process. Anybody can have concerns with that delegation process, whether it be to an individual or an entity like a vendor or clearinghouse. Bob, okay.
Yeah, the only issue we had is ensuring that whoever has the delegated authority has proof that they have the delegated authority. So you don't want somebody updating a practitioner's information without proof that they have given them the right to act on their behalf.
Gotcha. Okay. I think we can go to the next slide. I apologize. We're moving through these a little bit quickly. Any bulk data verification intermediaries? Would a clearinghouse fall into that category? Maybe Mike, I'll call on you here. Michelle? Oh, go
Okay,
ahead, Mike.
yeah, I was just unmuted. Yeah, I think obviously, and Stanley touched on this, and I think others touched on this as well, is basically we need a low-tech solution and a means to curate this data in a, through an aggregated type function such that, it can be sent electronically, but the electronic enablement is through a vendor or clearinghouse.
Excellent. All right, Michael, I think we can keep moving forward. We do have a few polls at the end we want to get to, so we'll go through these. So technical standards, I guess this is an important one. We want to spend a couple of minutes on it. The argument is, should we be recommending multiple ways to report? So obviously, they're going to support fire, but do we want to allow other opportunities as well? Online portals, Excel files, Word files, even faxing. So maybe I'll ask Tammy to weigh in on this from the physician perspective. Michelle, why don't you go first then?
Thanks. A couple of things here. We do need to make sure that we understand the current standard in place as a standard is the 274. The fire opportunity is also an opportunity. So I do think the recommendation is to ensure that we are using the standard that is out in the marketplace today and ready, and it's actually working in the industry today. So again, understanding what we're talking about here, fire can also be a part of that, but we really do need to include what is actually out in the industry today.
Excellent. Mike, I see your hand.
All right, there, I'm unmuted. It's tricky. So yeah, I think along with what Michelle was saying, I think, you know, the other thing that we always talk about is to have some sort of a pilot, and that pilot has proven outcomes, and that these all stakeholders involved, including you know, providers, vendors, clearinghouses, payers, if consumers are involved, then, you know, whatever the scope is, that should be an end-to-end pilot. That should be an end-to-end pilot that is proven and tested before anything is federally mandated.
Excellent. Yeah, I think that the whole piloting issue is critical. It's got to be proven to work.
Right. And,
great.
and obviously that will also flesh out any you know, bugs or you know, capability functions or whatnot, such that it's ready for prime time and wide distribution and, you know, general availability.
Excellent. Let's move to the next slide, Michael. Think we could probably agree would be helpful. The question is this again part of the nice to have approach? Once I think if the data is made available through machine readable files, that will allow these third-party apps to come in and curate the data. I think that's what they're thinking. So if we go to the next slide, we can skip this. I think we can. I think we know what we're going to say on security. We talked about this. We can go to the next slide. We talked about the phases, the viable products. This is just what I think our argument here is. Identify the low-hanging fruit, get that done first, then look to expand. So we can skip this one and go to the next one. Building trust. I would just say if anybody disagrees with the contention that CMS might want to model their communication and outreach strategy on the transition to the MBA that occurred a few years ago, they really did a nice job in my mind of engaging with stakeholders. They had advertisements out in newspapers and TV explaining the MBI to Medicare beneficiaries. I thought it was a good model that they may want to employ here with the NDH. If anybody disagrees, let us know through the chat. And we'll skip ahead, Michael. We'll go to the next priorities. We talked about this. We can go to the next one. Human-centered design. I think what we've talked about is let's make it everything as easy as possible. Ease of use should be one of the priorities in the development process. And here we have Mike's suggestion about piloting to make sure that it is doing what they think it's going to do and be able to, again, continuously improve the product through outreach with providers and consumers. Next slide. Implementation. So let's go to the next poll. So we've got a few polls here to end our session today. The question is, rate the impact on the burden of providers if they are required to submit to the NDH and continue to submit information to other federal programs and commercial plans. So if it's just another reporting requirement, is that going to solve any problems, I guess is the argument. We're not seeing any reduction in burden, no reduction, slight increase in burden, somewhat of an increase. So yeah, I think what we're seeing with this is folks saying, listen, unless it's going to solve a problem, just adding one more data hub is, it seems redundant. So very good. Okay, so let's go to the next poll, number 8. Okay, here we go. So this one is the impact if they report only to the NDH, and that replaces the need to submit information to other federal programs and commercial plans. So if it works exactly as CMS envisions, would that decrease burden? I think we've had a lot of discussion today suggesting that it would, however, with a lot of caveats that there's a lot of challenges to overcome before that would occur. So we're seeing a slight reduction in burden, somewhat, and the majority saying a significant reduction in burden. Okay, Michael, I think we can close that and go to poll number 9. So this one, what would be the most important factor for your organization to participate in and rely solely on the NDH? So would it be a requirement, perhaps a regulation? Would it be a financial incentive or an established savings, relief from inaccurate data penalties, or a guarantee that participating alleviates the need to update the data? So majority are saying alleviation. All right. And we can close that and let's go to our final poll. And I appreciate everybody hanging in. So overall, if everything worked out as CMS envisioned, what would a successful NDH look like? Accurate provider information, accurate health plan participation information, accurate endpoints, or all of the above. So we're starting to see the majority saying all of the above, not surprising. So I think we can close that. And Michael, I think we can move to our last slide. And I wanted to really take the opportunity to say a few things. One, I wanted to thank, first of all, Michael McNutt for his phenomenal work, as he always does behind the scenes, making things go smoothly. Thank you very much, Michael. Big thanks to Nancy, Ed, to April, to Tammy, to Kim and Michelle for their wonderful work as facilitators. And with that, I'll turn it to Charles to give us his final thoughts.
Thank you, Rob, and thank you all for participating today. It's been really a robust discussion, and I think it really proves that this is an important item and is something that this is invaluable in our response to this question. Thank you again, and thank you to all. And one last person that Rob didn't mention was Rob. Rob did a fantastic job facilitating this, making sure that we listen to your questions and that we were able to give people the opportunity to speak. So thanks to Rob as well. And with that, we will conclude today's session and look forward to other events from the rest of the month, and we will be back in touch. We have a member-only annual meeting in a couple of weeks, so we hope you'll join us for that. All right, take care and have a good week.